So, speaking of action, our final session. So this is going to be moderated by Keshia Pollack-Porter, who is the Johns Hopkins Bloomberg School of Public Health Director. And with her, maybe I'll let you introduce everybody fully. And yeah, so here's our final session.
Thank you. All right, thank you so much, Goody. Good afternoon, everyone. Thank you for staying to the end. I am very excited and thrilled to moderate this session. This interdisciplinary session features international scholars who will focus on action and solutions to reduce health inequities and improve health equity for all. The full bios for the speakers are in the program, and in the interest of time, I'll briefly just say who they are. We have one of our participants on Zoom, but you can see all of their photos here. So to my far left over here is Nihaya Daoud. She is a professor of public health, social epidemiologist, and social activist, and is doing, she's founded several NGOs advocating for human rights, health rights, and women's rights, and is doing really impactful work on gender-based violence and many other issues, particularly for the advocating for health rights of Palestinian citizens. Next to her is Dr. Davel Valdés, who's an associate professor of surgery at the University of Medical Sciences of La Habana, and doing very important work with rural communities in Cuba and Bolivia, and excited for his comments today in terms of really focusing on what he's doing over in Cuba and the social determinants of health. Along with him is actually Tanya, Zachrison, apologies, who's going to help with some translation for Davel. So we're excited to have them both with us today for that second presentation. And then finally, we'll hear from Professor Bukola Salami, who's director of the Intersections of Gender Signature Area at the Office of Vice President Research and a professor at the Faculty of Nursing at the University of Alberta. Each presenter will speak for about 15 minutes or so, and then we'll have time at the end for questions and look forward to your engagement. So let me turn it over to Neha to get us going.
Thank you very much. So, and I want to thank very much the organizers for this very important and interesting day, and for inviting me to present our case in Palestine. I have to say that I also felt frustrated by the end of the day for all the presentation, but I think that sometimes this frustration is translated into action for us, and it's not that we just want to complain. No, it's different, and I think it's very important to realize that what see in all over the world, that people are frustrated now of the regimes. People feel failure of the neoliberal regimes, and therefore they go and vote for right-wing governments, and this actually has very strong effect on the changes that we see in the national health services in many countries. And I think one of the mechanisms that I will talk about is related to this, what is happening now also in the historic Palestine and in Israel. So back to my presentation, I'll talk about structural racism and persistent health inequalities among Palestinians. I think as part of providing solutions, I think it's important also to understand the mechanisms, understand the complexity of the problems. And so the aim of my presentation is to situate Palestinians' health within the framework of indigenous health, to understand these mechanisms and the mechanisms of structural racism for persistent health inequalities. So I think I don't need to present how settler colonialism affects indigenous health, and causing post-trauma and physical and mental health problems, chronic problems, poor social determinants of health by indigenous people, and also poor access to healthcare services. And we witnessed also the intensified health inequalities during the COVID-19. Structural racism works in different ways to maintain its power structure through structural racism. So it dominates dominates the lands, and do house demolitions and displace people, assimilation of the indigenous people, many acts, many strategies to stay in power. One thing that actually defines settler colonialism from colonialism, that it comes to stay. While colonialism many times it comes and it knows that it's going to leave. So it doesn't work on assimilation of people. It just distinct itself from people, while settler colonialism wants actually to stay and occupy the land and change the people who stay. Sometimes they give them citizenship because they want to get international recognition. And the healthcare system is one of the systems that settler colonials or settler colonialism work through. So many times settler colonialism actually controls the healthcare system, and it works as an arm for the settler colonial and it to control people and control their health through the working on the healthcare system. So the healthcare system becomes a system that actually strengthening the occupiers or settler colonials of the indigenous people. Palestinians, despite being colonized and settler colonials for more than 1 century, they were not recognized as indigenous people, not by the international community and not by the researchers. So for example, the last Commission for Indigenous People did not include Palestinians. So they were denied, yes, the international rights as indigenous people according to the UN Declaration of Indigenous Rights. So, what happened is when the British colonialism came to Palestine, and they actually helped the Zionist movement to establish their homeland in Palestine, they claim Palestine as a land without people to people without a land. And this continues after that. So we see this now in different writings of historians. But so my actually talk will focus on the Palestinians who stay in the land, not the Palestinians in the occupied territories in Gaza and the West Bank, which you heard about. But we are about 2 million Palestinians who stay in the land, and we were about 150,000 people in 1948. While the other 80,000 Palestinians were expelled and became refugees in different countries. 500 villages were destroyed in 1948. Most of the Palestinians who stay in the land, the indigenous Palestinians, they became citizens of Israel and according to the law of 1952. They didn't have a choice. And most of the lands of those who stay in the land were confiscated. About 90% of the land that was confiscated, homes were destroyed, and the Palestinians became a demographic minority in Palestine. So today we are about 20% of the population in Israel, and actually Palestinians in Israel suffer from institutional racism, and because they became a racialized minority by law. There are different laws that discriminate Palestinians. The law of nationality, which recognizes Israel as a Jewish and the democratic state. Law of return that oblige only Jews to come back to Israel, to live in Israel. Law of family unification, law of Nakba, and many, many other laws. So Palestinians are treated as second-class citizens, and they lack political power. And therefore, they are also created unequally by policies, the discriminatory policies, unequitable distribution of services and resources, and they became second-class citizens, and also they have lower class because of lower education, income, and employment as an outcome of the policies that I just mentioned. All of this affected the health of the Palestinians and their social determinants health, and this led to inequalities in health. So what we see, despite the universal healthcare services in Israel now, we see that Palestinians have major inequalities in different health indicators, and they suffer from inequitable access and availability of healthcare services. For example, life expectancy for Palestinians, men and women, as you can see here, is 4 years less, and the gaps are just increasing with the years. Infant mortality is 3 times higher, and they suffer from different causes of diseases, as you can see here, more than the Jewish population. Mental health is becoming an issue with 3 times higher postpartum depression among women compared, Palestinian women compared to Jewish women, with many barriers for treatment, which were also related to multiple forms of discrimination among women. Discrimination was also a very important factor for depression and anxiety among Palestinian men. Policies like house demolition were related to depressive symptoms among women, and anxiety among women was related to the poor situation and conditions of the neighborhoods in the Palestinian towns and villages. Because in Israel, 80% of the Palestinians live in separate towns and villages from the Jewish. Only 20% live in mixed localities. And when they live in mixed localities, they have specific neighborhoods that they actually live in. So this actually increased the possibility of discriminating this minority, the Palestinian minority, with policies and research. It's easy to discriminate when you have them in geographic containments and villages and towns. So when COVID came, this was no surprise that Palestinians will suffer more. So we saw that Palestinian villages and towns were more red according to the traffic light monitoring system in Israel, more red than the Jewish towns and villages. And and morbidity was really higher and mortality was really higher for the COVID. So if we look at the healthcare services for Palestinians, we can see many inequalities, starting from hospitals that none was established in any town after 1948. There are 3 hospitals in Nazareth that were established before Israel was established. But for the new hospitals, none was established. So Palestinians have to travel to Jewish towns in order to get hospital care. Centers for child development, emergency services, laboratories, and the specialist care are lacking, and Palestinians have to travel to the towns of the Jewish where they can get these services. There is a severe issue of the psychiatric care should be provided actually in the patient language, but we see that according to the statistics of the Minister of Health, there are only 2% of psychiatrists who speak Arabic. Despite these inequalities, we see, or maybe because of these inequalities, maybe we see that Palestinians pay more for their healthcare services. So in additional to the universal healthcare services taxes that they, in addition to the health tax that they pay also for out-of-pocket money for the healthcare services, because they go more and more for private care because the public care is less existing in these localities. And in addition, we see in different research that we conducted recently that there are also discrimination and racism within the healthcare services. We have been looking at the separation of mothers in the maternal care units in hospitals, and looking at racism in healthcare, and we see that Palestinian women reported much higher racism and mistreatment because of their ethno-national identity. Looking at the healthcare workers in the healthcare system, so we see that Palestinians are increasing, okay, despite all what I said, the number of Palestinians in the healthcare system is increasing. For example, we see that about 50% of the pharmacists are Palestinians now, about 1/3 of the nurses are Palestinian in the healthcare system, and physicians are about 25%. And as you see, the license for the Palestinians is increasing. So now there are more Palestinians working in the healthcare system, which is great on the one hand, but on the other hand, we don't see many of them occupying high positions, our managerial position of decision-making in the system. And so they are not involved in decision-making. And we see that less than 1% of Palestinians occupy a higher position in the headquarters of the Ministry of Health. Only 2 directors of hospitals are Palestinian. The National Institution of Healthcare Services, which actually is responsible for funding research, includes only 1 Palestinian out of maybe 50. And the National Councils for Health and the National Emergency Teams actually do not include Palestinians. So why this happens? Because most of the position, the high positions in the healthcare system are occupied by persons who come from military ranks. So if you are coming from a military rank and you are a physician, you will compete for a position in the Ministry of Health for managerial position, you're likely to get that because you have also your military experience in addition to your civil experience. So in this case, the likelihood of Palestinians to be occupying these positions are less. The commodification of healthcare services was mentioned all day today, and it is happening also in Israel healthcare system, where the national expenditure on health is decreasing. It's less than the average in the OECD countries, and as you can see, this affected the physicians and nurses, and there is a lack of physicians and nurses in the country, and so the distribution of physicians and nurses in the country is unequal, and specifically in areas where Palestinians live in the south and the north of the Galilee and in Jerusalem. So we see that the percentage of physicians and nurses is less. So many of the statistics that I showed here, many of them about the healthcare coming from reports of the Ministry of Health. But these reports actually, what they do, they show the numbers, but they don't actually analyze why this is happening. And in this case, we see a stigma and also a victim blaming approach towards Palestinians. Oh, you're like this because you want to be the way you are looking, and it's not because of the discrimination or discriminatory policy in there. So what I did recently, I actually conducted a historical narrative review to show how to analyze the health policies toward Palestinians in the last century, starting from the 1980 during the British colonialism until the COVID. And I think this actually helps to understand the mechanisms of the persistent inequalities towards Palestinians. So looking back from the 1918 to 1948, during the British colonialism, what happens is there was actually underdeveloped healthcare services after 4 centuries of the Turkish role in Palestine. And so there was no actually developed healthcare system. There were spread physicians and nurses, but at that time also infectious diseases were spread, and the Jews at that time were about 6% of the population of the historic Palestine. But the British colonialism actually made them partners of the governing the country, and they actually get assistance to establish the healthcare services that became sick funds after that. So it was established during that time. The Nakba of 1948, I don't have to talk about, I think, the effects of the Nakba on the people when the land were occupied by the Jewish Zionist movement, and there were severe restrictions of the of movement for Palestinians over 20 years. So they were under military rules for 20 years. And at that time, the Jewish state actually started to build its institutions, and they actually built separate healthcare systems, one for Palestinians and one for Jewish. And so what happened is the healthcare needs of Palestinians were forgotten at that time, and all the healthcare needs of the attention was paid to the healthcare needs of the Jewish immigrants who came to Palestine. So and at that time, actually, the inequalities started to grow, okay, after that time. So in 1967, the military rule were removed from the Palestinians, and they were free to move, but they lost the lands, they lost their homes, and many of them became workers in the Jewish market. So they could actually get health insurance only if they work for factories for the Jewish, because the health insurance was provided through the workers. And so the worker union, which is the Histadrut that belongs to the Labor Party, actually provided this insurance. And so many of the Palestinians who did not work in this organization actually did not have health insurance. So the inequalities grow, right? And after 1993 and 1994, the National Health Insurance Law was introduced, which is the universal healthcare services. And first time Palestinians have universal healthcare services. Okay, this is great, 100% of them. But what happened? Still, we see inequalities in health because actually the historic picture continue, the underdevelopment of healthcare services continues, and the sick funds actually continue with their policies. And we know that the National Health Insurance Law failed to close these gaps. Only in 2010, when Israel joined the OECD countries and the health inequalities were started to be monitored by the OECD countries, then some attention was paid to the health inequalities. A unit was established in the Ministry of Health, and we thought that some changes are coming. But what we see actually that despite the policy of reducing the gaps, and despite this unit was established, still the inequalities continue. I showed you the numbers before at the beginning of this presentation. So sometimes the policy of reducing the gaps doesn't work. So what really works is something that we need actually to think about. Well, during the COVID, I already said what happened, and we now are after the COVID. So just to summarize these mechanisms that I talked about, so the historical political context of the Palestinians and the denial of their status as indigenous people and not entitled to indigenous rights led to racializations of the Palestinians, treating them as a racial minority, and because they lack power, so it was easy to discriminate against them with policies, with institutional policies, and it was easy also to have an unequitable distribution of resources and the power for this minority. So, and out of this, I think that this caused actually racialization of healthcare services. So what does this mean? This means that the healthcare system acts as an arm of the settler colonial state, where they actually, it is controlled by, you know, one side, not the other side, and it helps actually the governments to control the population, and because it is militarized, because, you know, the positions are occupied by military ranks people, so this actually maintained. What helped this racialization and the discrimination against Palestinians is the commodification of healthcare services. Always when there is a commodification of healthcare services, the lower classes suffer more. And all of this actually created what I call settler colonial healthcare, which actually marginalized the indigenous people, underdeveloped healthcare services for them, discriminate the healthcare workers, the indigenous healthcare workers, using a victim blaming approach for not developing healthcare services for this minority, and actually bringing stigma to them. And also, I did not talk about historical invalidation of traditional medicine, but this happens in many countries in the world that have indigenous people, and also in Palestine. So all of this actually led to the persistent health inequalities towards Palestinians. Now, 1 minute of what to do. Yes, because obviously here, when we talk about reducing the gap policies, it's not working. I think the solution should be first to start with recognizing Palestinians as indigenous people that are entitled to indigenous rights. And this is what our Palestinian Knesset members parliament members were trying to do, writing to the UN, trying to actually get this acknowledgement. And but of course, the Israeli governments don't pay any attention to this. And once you acknowledge the Palestinians as indigenous a group, then you have to acknowledge also the racial inequalities that they are facing, and also the historical injustice, and maybe changing the approach toward Palestinians from victim blaming to more equity-based approach. And of course, then the healthcare services should actually work towards closing the gaps for accessibility and availability of healthcare services, acknowledging actually the political, economic, and social context of the Palestinians. Thank you very much for listening.
Thank you, Neha. Okay, Davel? Yes.
Well, I want to thanks to all the organizers because this is an amazing event, and I want to thank especially to bring voice to the South too. In my case, I came from Cuba, and I will speak in Spanish. So if you can understand Spanish, you will be happy because it has been a long day all the time speaking in English, and Tanya here, it will be my translator.
Not needed, obviously.
Well, anyway, so, como dije, en Cuba el panorama es totalmente diferente a lo que hemos estado hablando durante el día entero de hoy. Y me imagino que muchos de ustedes ya hayan estado ahí y probablemente muchos también hayan estudiado sobre el sistema de salud cubano. Y yo vengo a hablarles un poquito de 3 momentos importantes en su evolución. Vamos a hablar entonces de en el 2020 cómo se mostraban algunos indicadores de salud.
So Cuba obviously is a panoramic picture of something totally different from what we've been speaking about today. Davel will talk about 3 different stages in the history of Cuba, but he imagines that many of you have probably been down to Cuba, so hopefully this will be interesting.
Ok, la esperanza de vida en el año 2020 para la población cubana, ambos sexos, era de 78 años. La mortalidad infantil de 4.9.
So life expectancy in 2020 in Cuba was 78 years old, and infant mortality also at that time was 4.9%.
La mortalidad materna era de 40.
Maternal mortality was 40.
Las camas por paciente, 5.2 camas por cada 1000 pacientes.
And 5.2 beds, hospital beds for 1,000 patients.
Las causas de muerte similares a las de los países desarrollados, cardiovasculares, cáncer y cerebrovasculares.
And of course, the main causes of death were very similar to high-income countries such as cerebrovascular diseases, cardiovascular diseases.
Ok, y eso era un país del tercer mundo con una economía que ha luchado durante mucho tiempo con muchas dificultades, pero ¿cómo era eso en 60 años delante de eso? En 1959, la esperanza de vida era de 35. La mortalidad infantil era de 34.8 por cada 1000 nacidos vivos. La mortalidad materna era de 137.8.
So the metrics we shared with you, those are metrics that are in 2020, and this is for a undeveloped country or underdeveloped country that's had a lot of economic hardships. But let's talk a little bit about what Cuba looked like prior to 1959 in terms of health. So life expectancy in 1959 was 35 years of age. Infant mortality was 34.8 per 1,000 infants born, and also maternal mortality was a whopping 137.8 per 100,000.
Okay. Las camas por pacientes eran 3.3 por cada 1000 y el 80% de ellas estaban solamente en la capital. Las enfermedades que causaban la muerte, como primero, las enfermedades transmisibles, diarrea, enfermedades como respiratorias y la tuberculosis.
So again, hospital beds, there are 3.3 per 1,000 patients available. And interestingly, 80% of hospital beds available in 1959 in Cuba were located only in Havana. And also in terms of causes of death, you're looking at causes of death that were common in low-income countries such as infectious diseases, diarrheal illnesses, and transmissible diseases.
And now, y ahora entonces vamos a los determinantes de salud. ¿Cómo cambió eso? En 60 años, ¿qué cambió de los determinantes de salud? Pues precisamente se modificó el analfabetismo y de un 22.3% de analfabetos llegamos a un 0%. No en el año 2020, estamos en un 0% desde los años 70.
So how, over those past 60 years or so, how did they address these social determinants of health? What changed? A lot. So as you can imagine, they started addressing the social determinants of health after the revolution of 1959. starting with literacy. So that was like an important campaign that they had. And in 1959, the illiteracy rate was at 22.3%. And it's been 0% in 2020, not because it's progressively diminished, but actually it was 0% very early on because of
70s.
In the 70s because of targeted campaigns.
Ok, los médicos por habitantes en 1959 era un médico por cada 1.064 habitantes. En el 2020 es un médico por cada 108 habitantes. Los estudiantes de medicina en 1959 se graduaron 186.
So roughly, again, doctors per citizens, it was one doctor for over 1,000 citizens in 1959, with again 60% located in Havana. Now in 2020 period of time, we're talking about one physician per 108 people.
Y los estudiantes de medicina en 1959 se graduaron 186. En el 2020 se graduaron 10.163 estudiantes de medicina en un solo año.
So this is a very interesting statistic. In 1959, there were around per year 186 medical students that would graduate. 2020, that's as high as 10,163 medical students that would graduate.
Y entonces, ¿con cuánto dinero hizo Cuba eso? ¿Cómo lo cambió? Entonces, antes de 1959 se gastaban aproximadamente 13 pesos por $13 per habitant. Now we are spending more than $300 per habitant. And it's also 10.47% of our internal gross domestic product.
Gross national product. Yeah.
Gross national product. So there is a lot of work on that. But no ocurrió sencillamente en 2 o 3 años. Hubo subsecuentes cambios. En 1959 teníamos 3 sistemas de salud. Privado, de seguros o mutualista, como se llamaba, y público.
So in 1959, there were 3 types of healthcare systems. One was public, one was private, and one was an insurance-based system.
El privado del primer mundo. Lo mejor de lo mejor comparable a los Estados Unidos.
Private was great. It was like first world standards, just like in the United States.
El mutualista, una calidad aceptable, pero solamente para los trabajadores. Y el 40% de las unidades estaban solamente en la capital.
So this mixed mutualistic called health insurance plan was mainly for workers that were insured through their workplace, and it was 40% of this coverage was located in the capital.
Y el sistema público, pésimo. Pésimo, totalmente pésimo. Tenía alrededor de 200 unidades con total ausencia de recursos, no solamente materiales, sino también humanos.
So I probably don't need to translate that last line for you, but like the private system or the public system was horrible. There are only 200 units across the country and really no access of not enough resources available, not enough healthcare providers available, but it was terrible.
Okay. Solamente se reportaban menos del 90% de la mortalidad infantil, porque sencillamente en el resto del país no se tomaban las estadísticas, era únicamente en la zona de la capital.
Oh, so interestingly, it was less than 90% of infant mortality rates that were captured across all of Cuba and largely focused in the capital city because they just weren't reporting statistics in rural parts and parts outside of Havana.
En la primera etapa de transformación, en los años 60, la primera ley que se estableció fue la del servicio rural social. Y sencillamente era que los médicos, una vez graduados, debían trabajar en las comunidades rurales.
So the first step of change in the 1960s was the law of social medical service, if you will, which was upon graduation from medical school, newly graduated doctors would actually go to rural areas of the country to offer their services.
That's still been the same. The first students in the record, the best students of the university, they went to the hardest part of the country, the mountain, to the rural areas, to the worst neighborhoods. We are working there. If you are in the first 10 in your graduation, you will be working on that, probably, likely. So, en 1961 se estableció una sola unidad y se reunificaron todos los servicios de salud bajo un solo mando. Y fue el comienzo del cambio, el real comienzo del cambio.
So in 1961, we had mentioned previously that there were multiple different medical units across the country. They united together underneath a unified system of public health across the country.
No fue fácil, hubo mucha resistencia y hubo que contar con los graduados, con las universidades, con los que quisieron y renunciaron a la práctica privada como fuente de enriquecimiento.
So this was a huge change if you think about it, because you really had to depend on new graduates from the universities that were amenable and agreeable to no longer work in a private sector because it didn't exist. You had to count on universities that would support this new system of public health throughout the country.
So
It was not easy.
that can't be done with only 100 graduates per year. So the second task was just spread the university all over the country and create new universities all over the country.
What he said.
Okay.
Oh, no, it's good.
So, en 1970 todas las unidades se lograron integrar y se creó una nueva figura que creo que es única hasta ahora en mi experiencia en los 3 o 4 países en los que he visitado los sistemas de salud, y fueron los policlínicos comunitarios.
So the second step in the 1970s was a new way of offering medical care, is the creation of these, ¿cómo se llama?
Clinic.
Like just polyclinics across all the neighborhoods, across all the areas of Cuba.
Well, la función del policlínico no es sencillamente proveer servicios de salud a los que están enfermos. Su función también era prevenir la aparición de enfermedades en esas comunidades.
And so a big shift was also not just providing healthcare for people who presented with illness to the polyclinic, but it was also an important task that they prevent illness in the first place.
Después de Almatá, pues entonces se comenzaron a dirigir directamente hacia los determinantes del estado de salud de la población. Y surge en 1981, pero se instauró en 1984 un programa que creo que es único a nivel mundial, que es el programa del médico y la enfermera de la familia.
So it was after the declaration of Alma-Ata that really in Cuba, they did start to focus on the social determinants of health. And that led to the third step, if you will, where really they started this program that is quite unique. It's Médico de la Familia, the family doctor model, but also the family nurse model.
Y por cierto, hoy felicidades a aquellos de los que están presentes acá que sean médicos de familia, porque es el Día Internacional del Médico de la Familia.
And we don't know if there's any family doctors in the audience, but we want to applaud you and say congratulations, because today is the International Day of the Family Doctor. So any family physicians in the audience? No?
¿No?
Yay!
Pues bien, ese médico y enfermera de la familia en Cuba no sencillamente están ahí para resolver a los pacientes que están enfermos su problema de salud. Ellos realmente son los líderes comunitarios de transformación social dentro de esa comunidad y tienen la responsabilidad de identificar los factores de riesgo y aquellos problemas que puedan ser solucionados para trabajar con la comunidad y los actores políticos locales en la transformación de ese estado de salud de la población.
So one thing just to mention also, when we talk about the family doctor, the family physician of this new system for families in Cuba, we're talking about one family doctor for approximately 100 Cuban families where they actually live in the communities that they take care of. Probably most in the room know that, but just to clarify that. And what's interesting is, again, to reiterate, it's not just the family physician intervening on sick patients that will see them, but the family physician will actually go to the patients, but also work with local community leaders to say, what are the social determinant challenges of our neighborhood? Because it's truly their neighborhood, because they live in that neighborhood as well. How do we address these social determinants of health with the local political leaders, the local community leaders, and the family members, so that we can increase health and improve health for everyone here?
Pues con ese programa que se empezó a instaurar a nivel nacional en 1984, aún después de la década del 90, cuando ocurrió el colapso de la Unión Soviética y la situación de la economía decreció un 35% del Producto Interno Bruto en Cuba, se mantuvo la expansión hasta ocupar todo el país. Incluso los lugares más remotos en las montañas de Cuba tenían un doctor o tenían un médico de la familia.
So this family doctor model actually was established in 1984 it continued expanding even during the time of 1989, 1990, during the crisis of the collapse of the Soviet Union. So the government of Cuba did not stop expansion. They made it a point to expand this program so that even in the furthest reaches of the mountainous areas, rural areas, everyone had a medical doctor available.
Como estábamos hablando, es mejor prever que tratar. Y es incluso económicamente más factible prevenir la enfermedad a tratar al enfermo.
So obviously it's much better to prevent illness than to treat it. And there's also a strong economic rationale for that too. It's a lot cheaper to prevent illness than it is to treat it.
En esa misma etapa de los 90 comenzó a cambiar algo que hasta ese momento Cuba había llevado en los 40 años previos, y era la colaboración médica internacional y la colaboración médica para la educación en medicina o ciencias médicas en general.
So before the 1990s, for the previous 40 years or so, Cuba had actually started to engage in what they call international medical solidarity and collaboration. So this was based on a program of having physicians, but not limited to physicians, but healthcare workers to go to different countries around the world, but also to engage in in providing medical education for students from around the world as well.
En 1998 se creó la Escuela Latinoamericana de Medicina.
So in 1998, the ELAM, or the Latin American School of Medicine, was established in Cuba.
Y comienza la tercera etapa o la quinta etapa, estamos hablando de los años 2000, donde ocurre una modernización a punto de partida de una mejoría en la situación económica del país y al establecimiento de relaciones multinacionales, sobre todo con Venezuela.
So now we're moving into the fifth stage of the development of the healthcare system in Cuba. This is in the year 2000s, where there's a generalized modernization of the healthcare system. There's a strong international collaboration, and also a collaboration that, instead of it being just purely based on solidarity with no remuneration, now there's a bit of remuneration entering from countries like Venezuela.
Y a su vez también se mejoraron los servicios de urgencia y creándose el sistema único de urgencias, opción como lo conocemos.
And also even emergency care was improved, and they have a emergency network of transportation, ambulances, that type of thing, first responders, called the SIUM.
Pues cuando hablamos del ELAN, ese proyecto, aunque parece increíble, era absolutamente gratuito para los estudiantes que estaban ahí. Se les brindaban todas las facilidades, tanto para llegar a la universidad como los medios de vida durante el periodo de los 6 años que dura la carrera en Cuba, y de la primera y segunda graduación se les dio la oportunidad de hacer las segundas especialidades, tanto hacer medicina general como hacer una segunda especialidad, dígase una especialidad del nivel secundario de atención.
So when we're talking about ELAM, or this Latin American School of Medicine located just outside of Havana, it's really important to understand that this was like something very unique in the world. Why? Because basically not only was tuition free, but Cuba would actually support students with funding to fly them over from their countries to support them in the medical school, food, room, board, shelter, all of that was paid for. And that went on actually even beyond medical school to even the first stages of residency, or even graduating from specific residencies. And in some cases, many students could have the option of opting for 2 residencies. So general internal medicine, and then even a surgical subspecialty or specialty like Davel has done.
En la sexta etapa, pues entonces hubo que hacer un reordenamiento económico y hubo que empezar a buscar otras fuentes de financiamiento. Y ahí es que entonces Cuba empieza a utilizar sus potencialidades en la formación académica como un método de compensación. Y se abrió la oportunidad de que estudiantes internacionales pudieran ir con becas pagadas, es decir, que ellos pagaran o los gobiernos pagaran la educación posgraduada.
So in 2020, in that period of time, of course, as we know, the COVID is hitting, and there's economic hardships. There's the Trump regime in the United States that's worsening the sanctions. But okay. And so there, sorry, I'm jumping ahead a little bit. Sorry. There's also there's a bit of a financial remuneration in 2010 or so, where again, more of these medical missions abroad are receiving financial remuneration, as well as also Cuba was accepting now more recently graduated doctors to come over and do residency programs in Cuba, but also their governments would now pay the Cuban government to teach their new doctors a certain residency program and specialty.
And keeping up with the translator.
Sorry.
La séptima etapa, entonces ya comienza la crisis económica real en la que estamos en este momento, de la cual muchos pueden haber escuchado. Y se marcó desde el 2019, cuando las sanciones económicas que venían impuestas desde la era de Trump, pues entonces comenzaron a hacer realmente mella en la economía cubana desde todos los puntos, pero sobre todo desde el punto del abastecimiento de petróleo. La primera señal fue en el 2019, cuando hubo una ausencia total de combustibles en el mes de enero y hubo que prácticamente paralizar el país.
So again, I had mentioned briefly the economic crisis in 2020 and all the reasons leading to this. But again, just to understand, for example, in 2019, there is a complete crisis where there's no petroleum in the country and transportation is grinding to a halt, which is similar to the first special period in the late 1990s.
Las afectaciones que esas sanciones crearon durante el año 2020, de abril a diciembre del 2020, ascendieron a los $198,348,000.
So the results of the sanctions during this time in 2020, basically it's leading to 200 million, or is close to 200 million to actually $400 million.
Las afectaciones históricas entonces son de $3.272,300,000.
So basically, historically, the bottom line is all of these sanctions and the economic hardship has cost Cuba well in excess of $32 billion.
Algunos de ustedes deben estar al tanto de las sanciones que ha impuesto el gobierno de los Estados Unidos sobre determinadas naciones. Y recientemente artículos han salido sobre cuál es el efecto de esas sanciones sobre los pueblos en los que esas sanciones son impuestas. En el caso de Cuba, para que tengan una idea, ningún barco que atraque en puerto cubano puede volver a atracar en puerto estadounidense en 6 meses. Ninguna institución internacional puede financiar o hacer préstamos a los bancos cubanos o al gobierno cubano, so pena de ser sometida a sanciones por el Departamento del Tesoro de los Estados Unidos, retirándole los fondos que los Estados Unidos aportan a esas organizaciones.
So many of you are probably well aware of the US sanctions and the impact on Cuba, but just to give you a granular idea as to what it means. For example, international ships that dock in Cuban ports cannot dock in US ports until 6 months have elapsed. So it basically closes the US market to so many other countries. No country can give a financial loan to Cuba. Cuba cannot keep their money in foreign banks, or else the United States will go and literally just absorb the funds, which could be over hundreds of millions of dollars, and then put a sanction on the banks as well, put a fine on the banks.
Por ejemplo, durante el 2020, epidemia de COVID, desastre total. We are finished. Okay. Promega, la corporación Promega, que suministra equipos para diagnóstico de enfermedades genéticas, prefirieron que no podían suministrar a Cuba el kit de diagnóstico. Brunker, spectrophotometer, they denied to sell to Cuba an spectrophotometer. Stryker, and extensible prosthesis, no answer. Boston Scientists, no answer. Zimmer?
Yeah. Lots of when we're happy, we can give you the examples of multiple corporations promising or denying access to urgent and necessary medical therapies and equipment and technologies.
Banks, too. UBS Bank Clear, Banco Cantonal de Basilea, they refused to proceed transaction to Cuba. Chips, airplane companies, they refuse to transport healthcare products to Cuba. For example, just to say, la Agencia Naviera de México no puede transportar una de las mayores que tiene México no puede transportar productos a Cuba porque tiene negocios con Estados Unidos. Y quien tenga negocios con Estados Unidos o un 10% de un producto cualquiera tiene que ser capaz de verificar que ese producto no es usado por el gobierno. Y al principio empezamos diciendo que el 100% de los hospitales en Cuba son del gobierno. Por tanto, y más es extremadamente difícil que podamos usar eso.
So we're wrapping up, but just something that is important to understand is under the Torricelli law, which is now from the early 1990s, any US subsidiary abroad cannot trade with Cuba according to US law, which is actually an illegal law. So it's internationally illegal because US subsidiaries are beholden to the local laws of the country in which they function. So Naviera, Agencia Naviera from Mexico, a very common Mexican company, for example, Avianca Airlines, so many of these corporations and companies, also, even without being US subsidiaries, simply for being an independent company in a sovereign nation, if they choose to do business with Cuba, the United States will choose not to do business with them. So they lose a lot of money. ¿Cuál fue la otra cosa que dices? Yeah.
So to my friend from Greece, we are not afraid to say the word C, capitalism, but be aware to say the word S, socialism, because you could have a lot of problem with that.
Thank you. Thank you. So we'll go to Bukola now. Bukola, we're ready for you here now. Thank you for being with us. Who we see here on the screen.
Thank you for having me. I just need to share my screen. I am located in Treaty 6 territory, which is in Alberta. It's the traditional gathering place of diverse indigenous people, including the Cree, the Iroquois, the Blackfoot, and many others. And their languages, their culture, and their history continue to enrich our vibrant community. So in Canada, we have 1.5 million people that identify as being Black, and that's 4.3% of the Canadian population. Black population are generally younger than the general population. And in Canada, we have what I call the cappuccino effect. And the cappuccino effect is, like we see in many countries, we see also in the US, that the health workforce or even the general workforce is like a cappuccino. It's Black underneath and it's white on top. And this has implications, such as during COVID-19 pandemic, we saw not just in Canada, but also in the UK and the US, we saw that Black population had a higher rate of contracting COVID-19 in its early days and dying from COVID-19. And that's because they tend to be concentrated on the bottom hierarchies of the healthcare ladder, and thus they are more likely to have exposure to people that have COVID-19 as opposed to people that are concentrated in management positions that tend to be white. I recently did a study looking at the pap smear and mammogram among Black and other racialized groups. And here I compare Black, white, and indigenous. In Canada, we tend to think that Black people have a poorer education, but that's not true. On average, Black people actually have more education than white people in Canada. But there is a caveat. The reason why Black people have more education than white people is because of immigrants that are well educated, that we select people that are well educated to come into Canada. The question is that when they come to Canada, their children are less likely to attain the same level of education as their parents. So children born in Canada tend to have a lower educational achievement, but in general, because of the immigrant population, the African immigrant population, especially those from West Africa, that tends to pull up the educational outcomes. But we also tend to have one of the lowest income distribution. So high education, low income for Black populations. So Black children are one of 2 groups in Canada who do not surpass their parents' level of education. So generally over time, people tend to have more education on average than their parents, apart from Black population. And the other population is Filipino populations too. And for Filipino population, it's mainly because of the de-skilling that happens through the Living Caregiver Program, a program that allows people, many of whom are from the Philippines, to come to Canada to work as living caregivers. And many of those people, they're educated in their country and they come and work as domestic workers. And the de-skilling has then consequences for the children. It gets passed through generations. And among Black people too, it's sort of the same thing. The de-skilling that Black immigrants faced gets passed also to their children, and also the historical history of racism and also historical history of slavery. And Black youths experience poorer educational achievement than other youths. This is despite their high educational aspirations and resilience. Negative attitudes of teachers towards Black youths, lack of African Canadian history and culture in the curriculum, systemic racism, low teacher expectation, alienating school environment, and lack of Black teachers and mentors contribute to this. And in Canada, we do, I think oftentimes, we do not know about the history of racism in Canada. Between 1968 and 1910 and 1968, there was actually a policy in Canada that prohibited on a stated period or permanently the landing in Canada or the landing at any specified port of entry of immigrants belonging to any race deemed unsuited to the climate or requirement of Canada, or of immigrants of any specified class. And this was because we had around 1910 and around that, there were Black people that were trying to come from the US, including those in the slave industry, trying to come from the US to Canada. And the way to ban these people was for Canada to implement a law and say, oh, it's too cold here, your race cannot survive this weather. So it was really a racist policy, looking for a reason to try as much as possible to prevent Black people from coming to Canada. There was also other council, basically a proposal in Parliament that the Negro race is deemed unsuitable to the climate and requirement of Canada. Now, it was proposed, but it wasn't eventually passed. But in the process of it being proposed, it had consequences on Black people's outcomes in Canada. So in 2017, the United Nations Working Group of Experts on People of African Descent was in Canada to analyze the conditions of Black people. And what they concluded is in my last statement, that Canada's history of enslavement, racial segregation, and marginalization of African Canadians has left a legacy of anti-Black racism and had deleterious impact on the people of African descent, which must be addressed in partnership with affected communities. So after this, jump-started a series of interventions by the government to address some of the inequities that Black people face, such as, there was a setting up of a mental health of Black Canadian initiative with the Public Health Agency of Canada, and I am one of the members of those of the working group of the federal government's Public Health Agency of Canada to try and address some of the inequities Black people face, specifically about mental health. So I'll talk about the research project that I did with Black youths on their mental health. And this project, I was a board member of a Black organization, the biggest Black organization in Western Canada. And I was approached by youths to do this project on their mental health. So we interviewed 30 Black youths. We did conversation cafes with 99 Black youths. The interviews informed the conversation cafes we did. So the first interviewed conversation cafe was on health promotion. The second was intergenerational relations, so dealing with your parents 101. The other one was intersectionality. And the last one was policy. For the last one, the youths took their fellow youths, co-researchers on the team, took their fellow youths through thinking through what an ideal mental health clinic would look like. And based on what they were able to think about what an ideal mental health clinic will look like, they then presented that data to the executive director of Africa Center in Alberta, who then used it to create the first mental health clinic for Black Canadians in Western Canada. So some of our research findings includes experience of racism and discrimination. So there was one youth that said, God, I grew up with so much internalized anti-Blackness. God, I hated myself. I wanted to be white so bad. I wanted to have straight hair. I wanted to have lighter lips. I wanted a smaller lip. And this same youth talked about two occasions. There was an occasion where she was walking past the street and someone threw a Slurpee at her and called her the N-word. Another experience she had was, she was sleeping over at a friend's house, and they made fun of her, of her facial features, and that she had internalized and continues to affect her mental health. Black males also talked about issues related to intersections of race, gender, and masculinity. In my community, it's easy because obviously the community understands the struggle out there. Outside of my community, I need to start out with the notion that I'm not going to rob you, right? Or just kind of when I interact with white people, just kind of the first thing that I have to attack is the preconceived notion that I'm Black, I am a thug, or whatever. So for a lot of people, you're proven innocent. You're innocent until proven guilty. Not for Black population, you're guilty until you're proven innocent. And that continues to have a lot of pressure, especially for Black males who need to always show that they are not guilty, they are innocent. There's also cultural expectations. So the whole idea that mental health is a Caucasian thing, it's not a Black thing. So people don't pay attention. Academic expectation, many of the youths I interviewed were university students and some were in high school. And also openness about mental health and sense of community. In another study I did, I looked at mental health of immigrants and non-immigrants in Canada, and I analyzed data from 17,000 data from the Canadian Community Health Survey. What we found is the two strongest factors that contributed to mental health of immigrants and non-immigrants was income and community belonging. When people feel that they belong to a community, they're more likely to rate their mental health as higher. And when people have higher income, they're also more likely to rate their mental health as higher. Some of the barriers to access to health services include cost of health services. So in Canada, we do have medications that are covered, which means your psychiatrist will be covered, but your counseling psychologist is not covered in Canada. And oftentimes for most people, they have to pay out of pocket for that, unless if they have insurance, but many people, Black populations don't have insurance. And this will typically be maybe around $100, $200 per visit. And for many, they cannot just afford this. Geographical barriers and distance and service locations. So many of the mental health services Black youth started was located in white neighborhoods. Lack of demographic representation. So one of the youth said, she'll go to a mental therapist and she'll say, she'll go and say, I'm experiencing racism. And the person will be like, what? Oh, what? Are you sure? Okay, let's get you something else. So basically, the healthcare professional doesn't know how to deal with racism. So they try to skip over and move to something else because they don't feel comfortable talking about racism. And lack of mental health, knowledge of mental health services. Other factors includes intergenerational gaps. So for example, people specifically from Sudan who have been used to a lot of traumas, parents that have been used to a lot of traumas in the past, they expect that, just as they were resilient, that the child would also be resilient. And that influences the support that children receive. Stigma and judgmentalism, culture of independence, and also peer support, religious teachings and practices too. They often used to help deal with mental health challenges. So some of the implications of this includes the need to diversify the healthcare workforce to address anti-Black racism and also how it intersects with other social determinants of health. including income as a social determinant of health. So remember that racism does not exist in isolation. It reinforces other inequities and also intersects with other inequalities, such as income and community belonging, to lead to health inequalities. Capitalize and build on the resilience of Black youth, and build the capacity of religious and community leaders to address mental health and attend to geographical locations of mental health services. Thank you so much. And this was a stakeholder engagement day where we presented our results to stakeholders in the community. Thank you.
Great. Thank you so much. Many thanks to Nihaya, Davel, and Bukola for lifting up policies and actions to reduce health inequities in Israel, Cuba, and Canada. So we have time for questions. I have some, but I'm going to open up to the floor first. And please, there's mics going around. We'll get to our first person over there.
Hello, my name is Arnel Boras, but I'm not from Spain. I'm from Canada, originally from the Philippines. So I immigrated to Canada. I was also de-skilled. I started working as a factory working, earning minimum wage, work in long-term care, starting as personal support worker before becoming a nurse. I'm now in the academic world. My question is, it's clear now, based on throughout this day, it's very clear, overwhelming evidence that it's capitalism which is the fundamental cause of health inequities, and that it's entangled with its co-constitutives and racism and sexism, and we extend that ageism and ableism. So it's clear now that public policies are very limited in a capitalist system. So if that's the case, as scholars and activists, what are we going to do now? And what are the alternatives? And one person said here, I believe it's from Cuba, that it could be socialism. So I'm wondering, what is that type of socialism? What kind of socialism? How does it look like within the capitalist system or beyond the capitalist system? As I attend many conferences online, many organizations now are calling to move beyond capitalism, and in the climate change, they're pushing for eco-socialism, which I'm very interested and I'm curious what it looks like now. In one of my interviews, it said that it should not be like Russia or US that both consume the Earth's resources. If you can answer all these things, especially that capitalism is both gendered and racialized.
Oh, no, I was just going to see if...
how are we going to forge a stronger strategic alliance among scholars and activists?
Yeah, I was going to say, Davel, do you want to share? Or...
Well, I have a personal bias. No. I have been living in a socialist country for all my life. And what I can tell you is that for sure, health care and health issues in Cuba are a priority for the government. I think it's the #1 priority all over the country. I don't know what is the answer to tell you how to change how the world work now. For sure, we will need to work a lot, and this conference is just a small step on that. But I think we should create a lot of alliance. We should collect data. We should prove that there is another way to do the things, and it might be better for the humankind.
I think changing the discourse to health rights and health equity could bring us to a different maybe times regarding the importance of health and how government can change, because I think this discourse is very important, but I see that it is limited to some group of researchers, while others actually continue their research without paying any attention to that. So I think our medical schools, nursing schools, education, I think learning from you in Cuba and other countries who are doing this, I think this means that, well, if you actually implement this in the education training of the medical students, then maybe we can see more change. And I think this can bring also change to the governments, because if we are changing the discourse within the healthcare systems, maybe we can also affect other systems and then make some more global change. But I think political will is very important, because you said this, you said that the government has the health as number one. But yeah, in some countries, like in Israel, security is number one and military is number one. So if the money goes there, most of the money, then the social services, the healthcare, the welfare services will suffer. And this is what happens. And when it suffers, those who are at the not at the center of the so they will suffer more. Those who are at lower classes, they will suffer more. And this is what happens in our case. Yes.
Great, thank you. Bukola, you want to add here?
Yes, I think, one of the challenges we have is, sometimes we teach, but sometimes we do not require accountability for what we teach. So, I can speak at least at the intersections of racism, that oftentimes, people do training, we all get overtrained, but no one actually requires accountability in terms of from healthcare professionals. So I think one of the strategies that we can do here is that we need to advocate more from healthcare professionals, policymakers, to embed knowledge about social determinants of health and intersectionalities with issues related to gender equality and racial inequality into standards of practice and into evaluation frameworks. I looked at standards of practice across Canada, for example. For a lot of healthcare professionals, many of the standards do not even include the word "har" in it. Racism, it's nowhere to be found. And if you cannot, if you can be practicing, and if you're practicing, if you don't have knowledge about income inequality, you don't have knowledge about racism, you don't have knowledge about gender inequality, but then you can still say, oh, I am competent. That's really, really a problem that we need to embed. So I think infusing accountability metrics into professional standards of practice related to social determinant of health, income inequality, and other inequalities is very important.
Great, thank you. Other hand? Oh, we have another question. Yes.
Yeah, I'm not a member of the panel, but if I could take the opportunity to add a comment to our Filipino friends' question. Okay? I think there are socialists and there are socialists. Okay? You asked a question about socialism. What kind of socialism? Okay? Well, to my mind, is not a socialist with EU characteristics like Mr. Joseph Borrell. I promised myself I wouldn't attempt a joke at it, but I can't resist it. But anyway, to a more serious comment, okay, to share some experience of Malaysia. Okay. Dr. Mahathir Mohamad was on the international scene. He was a very independent-minded prime minister, okay, figure on the of the global south, okay, and he, despite U.S. arm twisting and pressures, okay, he developed very good relations with Cuba. Okay, apparently got along very well with President Fidel Castro, okay, and to the point that we were importing pharmaceuticals and vaccines, okay, from Cuba. Okay. Unfortunately, that lasted only until 2015. Okay. We were using, among other things, the recombinant hepatitis B vaccine. Okay. And I don't have it explicitly, okay, but from my conversation with the previous ambassador, okay, Ms. Ibete Hernandez, okay, my reading between the lines, okay, of a diplomatic phrasing, okay, was that our health ministry eventually caved in, okay, to US pressures, okay, to stop, on pain of being sanctioned, okay, to stop trading relations with Cuba, in particular the imports of pharmaceuticals and vaccines. 2015.
Well, that's the problem. If you are trading with Cuba, or if you have any kind of relation with Cuba, that you could be on the center of there's an office in the United States just for Cuba. It's a huge office just to follow up all the trades or the transaction, all the business, everything that is happening with Cuba, and it's founded by the government of the United States. So that's 100% true. During the pandemic, for example, the owner of Alibaba, Jack Ma, he donated $2 million in personal protection equipment to Cuba. And then those equipment never arrived to Cuba because the company who should provide that to Cuba or transport that to Cuba at the last minute say, well, no, I can't go to Cuba. That's not allowed for me. And that's happening in every single issue. That's our burden, I think. Yeah,
I'm sorry. I'm sorry. I know I'm just the translator and all that, but just like we've published about this, about the impact of sanctions on Venezuela in the Lancet and whatnot, but like it's a classic US foreign policy thing, which is interesting because where does that fit within the social and structural determinants of health? But using sanctions as a way to strangle a population, and then just waiting for the population to overthrow their government if they can't migrate en masse, and then saying, oh, look how bad that country is. Like Venezuela, they're not going to allow Venezuela to use PSDVSA, I think, or the petroleum companies to trade. And 90% of their GNP is based on oil profits. Like we're talking about liver transplants for children, bone marrow transplants for children. That's like oil profits that pay for that system. So if you cut off the oil profits on an international level, you're talking about direct shortening of life expectancies. You're talking about increasing in infant mortality rates, maternal mortality rates, child morbidity and mortality, which is deliberate. While you generate so much money off going to Iran and Cuba and Venezuela and finding banks that hold their monies and all that, like sanctions are a great way to make money for a country. But it's like absolutely in terms of a public health intervention, it's terrible, which is the whole point. Get the people to overthrow their government. Sorry.
I am happy for questions to go on as long as the audience is happy to sit here, but
Maybe we'll take one more in the
Sure.
interest of time.
Yeah,
I
yeah,
know
sure.
people are anxious for the day to end.
Thank you. As you know, I come from Mexico, and actually the Mexican government has resisted what is a sanction to Cuba. And I think that's important to say because Mexico is the second biggest trade between a country outside of the United States. So we actually, as a government and as a people, we have been resisting what are the sanctions for Cuba. And that should also go together with the history of Mexico, because the only Latin American country that didn't cut relations with Cuba, with the Cuban Revolution, was Mexico, actually. So I think that it is possible to resist this kind of interventions, and that should be also thought of, because that has been possible and it is still possible.
Actually, now the government of Mexico and the Cuban government has a lot of agreement in health care. Actually, there is a lot of doctors Cubans doctor who has been working there for a year. as a intergovernment relation or new kind of intergovernmental relation. And there is a lot of students or postgraduate students who are doing residencies in Cuba right now from Mexico.
Yeah, I think you are bringing me to a point that is important to mention, because what we see recently is many healthcare professionals immigrating from low-income, middle-low-income countries to actually high-income countries. And this drain of healthcare professionals from these countries to the Western strong countries might actually do lots of effects on the healthcare system and also the countries that send the healthcare professionals, but also countries who are receiving these healthcare professionals. And this is because of, the crisis in the healthcare systems, where there is a lack of physicians and nurses all over the world. And I think this will change for the recipient countries. This will change the composition of the healthcare workers, and maybe changing the attitudes towards healthcare workers, because racism that I talked about in our case maybe will change, because if you have more and more physicians and nurses in the healthcare system, then maybe in the future you can't actually avoid or ignore the fact that they will come in higher positions in the system. So, and then the question about racism from the patients and the other colleagues and the population, maybe it will change. This is one thing. But for the countries that are sending their healthcare workers, it is going to face really a shortage and a crisis, I think. But it is something that needs a global thinking. This is something that I don't think we are thinking seriously about this, but I think anti-racist education, for example, I talked about it before, and anti-racist systematic discrimination against workers and against populations. This is something that we have to look for.
Yeah. Well, thank you. I know we're at time, but I will encourage those of you who will be here to the reception to find our great speakers. And Bukola, I wish that you were able to be here for the reception to answer some questions, but perhaps people can follow up with you over email. So thank you very much. Thank you. Please join me in thanking the panel for this great presentations and conversations today.
Thank you. I'm so sorry that we have to cut that short, but I have to say that given that a lot of the day has maybe at times felt depressing, and the one was like, I think the one sentence that will stick with me is, this is the one thing I know in Spanish is el problema es el capitalismo, right? And that's the one thing that's going to stick with me from this whole day. But I think the reason that this panel was so hopeful for me is that even in the face of neoliberal capitalism, the global South is showing that there are ways to resist. And that's why this is really important, right? Yeah. And that's where these pockets of resistance are so important. And we need to learn from that. And that's why this journal could help surface those examples, because the truth is that people in the West don't know half of what's going on, right? And maybe we absolutely need to learn, right? So there is something about this panel that I thought was very hopeful, and which is why I let it go on, because I think it needed to be said. Thank you so much. I'm now going to hand over to Keshia, who's already here on stage, to round off our whole day with her closing thoughts. And then, well, we're almost at the wine part, so.
All right. Well, thank you. Thank you so much. I know it's been a long day, and I thank you all for being here. I just wanted to share a few things. In addition to being chair of the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, where the sponsorship of the journal currently lives, I have the great privilege of serving as co-director with Joanne Banach of the Johns Hopkins UPF Public Policy Center. And so on. Just want to thank everybody for making time to be here. It's really just been so exciting. And I'm hopeful for the end of the day, and I will share why in a moment, and want to just celebrate again this new phase of the journal that explicitly has been lifting up social determinants of health in its name, and will undoubtedly for the next 50 years and beyond push the boundaries and scholarship of how inequalities, power dynamics, structural injustices impact and shape the health and quality of populations worldwide. Through a number of panels today, we heard about time and time again of the importance of policy, of naming social determinants of health, of research needing to push the boundaries and bringing in things like political epidemiology and new frameworks around power and community. We've heard about policies and actions to reduce health inequities. We heard about the role of structural racism. And I hope that you found these comments energizing and thought-provoking. And I say energizing because the work we do is difficult. And I think it's okay to say that. It's okay to say we get frustrated. It's okay to say that it's tiring sometimes. And together in community, I believe that we can continue on the journey to do this work together. Speaking of that work, let me tell you a little bit about the work that we have to do in the US, because we have some challenges. Recently, our US Center for Health, Disease Control and Prevention reported that life expectancy in the United States in 2021 declined for the first time in a number of years and has been at its lowest number since the late 1990s. If you are a male who was born in the US, your life expectancy is now 45th place in the world, behind the European Union. And we know that there's also a disparity by sex. How could a country that is so wealthy, quote unquote, have such poor numbers? We also know that this decline in life expectancy that we've seen has been largely driven by the opioid epidemic, and then also, of course, falling precipitously during the COVID-19 pandemic. The decline in US life expectancy has not been uniform. The data reveal large gaps between communities of color. We see the dramatic impacts on Indigenous Americans, or American Indians and Alaskan Natives. And we also know the important role of community. For example, in Baltimore, in Maryland, where I live, there is a 10-year difference in life expectancy between neighborhoods just a couple of miles apart. You can't tell me that that's due to biology. At the root of these differences by race, ethnicity, geography, gender are the influences of income, education, employment, transportation access, food access, violence, capitalism, residential segregation, structural racism, and power imbalances, factors that impact how long we live and how well we are living, not only in the US, but also worldwide. As we've discussed today, throughout the day, we need to continue to place greater emphasis on the social, political, and economic contexts in which morbidity and mortality inequalities are produced and reproduced. We need to continue to conduct research as well as engage in knowledge transfer, getting information to decision makers, policymakers, and communities who can do something with the evidence. And I believe, at least in the US, we need to move beyond conducting descriptive studies. If I see another descriptive epidemiologic study about race differences, I'm going to scream, and focus more on research that gets at the mechanisms. Why? And focus on solutions. As a policy person, I believe that policy change is critical to helping address health inequities. And we heard about some policy strategies in the prior panel. We know that governmental and non-governmental policies are critical for health. My own work in health and all policies in the US seeks to partner with non-health sectors to bring health and equity to the forefront. When I think about policies, I also need to comment on the role of courts, and particularly in the US at this time. We know courts don't make policies, but legal decisions impact policy. In the United States, we've seen a rise in the role of the influence of courts and judicial decisions as determinants of health. For example, in 2022, a very conservative US Supreme Court in the landmark case of New York State Rifle and Pistol Association versus Bruin, a case that challenged New York laws regarding concealed carry of firearms, found that it was unconstitutional to ban people from hiding their guns. Let me say that again, carrying a gun in public is a constitutional right based on the decision of the courts. And what is incredibly disappointing about that landmark ruling is that we know that gun violence prevention policies help reduce the epidemic of gun violence that we see in the United States, an epidemic that disproportionately takes the lives of Black and brown people. We've also seen the courts in the US remove the right to access for abortion, remove the right to access for gender affirming care. And more recently and relevant for this conversation today is there are efforts to ban or limit conversation and use of the words like racism, equity, and even the history of Blacks and African Americans in the US. Earlier this week in the great state of Florida, Governor Ron DeSantis signed legislation to defund efforts funding diversity, equity, and inclusion at all public universities in the state, and limit how race can be discussed. DeSantis called these efforts a distraction from the core mission of academia. He and other opponents of diversity training said that equity and inclusion programs reinforce racial divisions and promote quote unquote liberal orthodoxy and is standing for discrimination actually, and has no place in our public institutions. Sadly, Florida is not the only state. We have many other states in the US, including Texas, seems to be on the brink of passing their own bans to ban people who are fighting to promote equity from even using these words. These policies, laws, and court decisions are part of the social determinants of health. It's part of why we're here today. And I know that these policies were developed and implemented by people in power who like to hold on to that power and keep certain groups of people marginalized. And I believe that it is people who will help us get out of the problem that we're in now. I believe in the power of community organizing and voting to change who are we put in public office so that they can have the power to shift power and dismantle existing racist and oppressive policies. This to me is critical for advancing health equity. Before I wrap with some comments, I want to talk a little bit about language. Today, we've heard some comments about social determinants of health and what do we mean? And I will say in the US, I've been very frustrated by people literally defining social as social and not acknowledging as much the social, economic, structural determinants of health. And this has really been a barrier to moving things forward. And because we have seen now that people are saying, well, let's talk about the political determinants of health separately. Let's talk about the commercial determinants of health separately, as opposed to thinking about all of these together. So my question I just ask is, what does that mean for the field? I don't have a clear answer, but we have to acknowledge that these things are happening. The other part of what's happening is the word determinants. There's a growing pushback in the US on using the word determinants, not determinants, ATS, determinants. These critics are asking, well, what is a determinant? And what does it mean to say that income is a determinant of health? Some people think that that is actually very harmful and suggests that we can't do anything because you're saying your income determines your health and therefore we can't intervene and correct it. And in lieu of saying social determinants, many are now saying social factors or social drivers. Again, I just want us to be aware and to ask, what does that mean for the field as we move forward? I will also say that while I support getting terms right and being clear on what we mean, I hope that we can all agree that whatever we call it, our lives depend on focusing on them. And I don't say that in terms of hyperbole. As Michael Marmot said this morning, the 2008 World Health Organization Commission on Social Determinants of Health report was highly influential in the US. For me, I was a young assistant professor at the time when the report came out, and it helped catalyze my focus on systems and structures and dismantling harms and moving from being described as a health disparity researcher to a health equity researcher. And I'm grateful to many of those who we heard today who laid the foundations for all of us to build on, especially want to call out Carlos and Juan, who we have heard are the co-editors of the journal. So before I wrap up, I want to just share one last thing about hope. I've often heard that hope is not a strategy. And although I agree with this statement, I also know that hope is an essential part of achieving a strategy based on what we believe is possible. I'm incredibly hopeful for the future, especially after being with all of you today. I flew in yesterday from the US. I will fly out tomorrow. It's a short trip for me, and I needed to be here. And although we talked about many challenges today that we need to work through, I invite you to join me in celebrating how far we have come and seeing what's possible for the future. I invite you to join me in having hope and working together because we know that we can imagine a world that is so much better than the world we live in now. So embrace the possibilities for what we can accomplish because they are endless. So thank you very much for being here. Thank you for allowing me to close out the conference today. Take care.
The question I have is, when is Keshia standing for office? Because that was amazing. Thank you for closing out this conference in no better way than I can imagine. And this is the end of today's proceedings. But before you go, you do need to hear from me, the chair, once more, because I have to say thank you. And I have to say thank you to a lot of people. Thank you to Keshia, obviously, for that beautiful final address. Thank you to all the speakers today who have been absolutely phenomenal, so inspiring. Thank you to all the people who presented their posters at the back. Thank you to all of you guys for putting up with me and for staying so long. Thank you to UPF and the Johns Hopkins UPF Public Policy Center for hosting us.